Right. Now coming to rabies. Quickly go through this. There's a little confusion in the vaccines for rabies. We clear that vaccines and there should not be any confusion. Rabies, it's also called as hydrophobia. It's an acute, highly fatal viral disease. Lissa virus type 1. It's basically a zoonotic disease, but when it comes to man, it ends in man and it is very fatal. Classical hydrophobia, as you know, clinical picture is that there is a long and variable incubation period, short period where there will be encephalomyelitis and then death. Whatever you do, you won't be able to save the child, and it's the only communicable disease of man that is almost always fatal. Clinical picture, it's called hydrophobia. It begins with prodromal symptoms like headache, malaise, sore throat, then becomes a little specific with pain or tingling at the site of the bite. This is the only prodromal symptom which is considered specific, which is pain or tingling at the site of the bite. This complains after 3 to 4 days after the bite. Now, prodromal stage is followed by excitation and stimulation of the nervous system. In order, first the sensory, motor, finally the mental system. So, the patient is intolerant to any sensory stimulus, light or air, aerophobia will be there, hydrophobia will be there, he can't stand light as well, and this can be elicited by even a small current of fan of air across the face. Now, prevention of human rabies. This is the component which you have to learn in SPM. See, they have a big chapter on infectious diseases in the textbook of PARC. As I told you, what you have to read is that component which is not there covered in the medicine textbook or your microbiology or your pathology. We are looking at the preventive aspects, curative aspects, more with emphasis on the community. Now coming to rabies. Prophylaxis, this rabies vaccine, will try to solve this puzzle today. There are 3 types of prophylaxis: post-exposure, pre-exposure, post-exposure of treatment, post-exposure treatment of persons who have been vaccinated previously. So, there are basically 3 types. Now, the vast majority of persons requiring anti-rabies are those who were bitten by a suspected rabid animal. You only suspect that maybe that dog has got rabies and that rabies virus is in the saliva. Because of the bite, that saliva has come into the skin of the human. Because there is a breach in the continuity of the skin, it has directly entered your blood vessel. That is the premise. Every instance of human exposure should be treated as a medical emergency. It is now well established that irrespective of the class of the wound, if you give an immunoglobulin along with the vaccine and local treatment, it is the best prophylaxis after treatment, after exposure of man to the rabies. So, you do not have to worry much when you have a very good prophylaxis available for this almost always fatal disease. Now, categories of contact and recommended post-exposure prophylaxis. This is the essence of it. Category 1 is where there is touching or feeding, skin is intact. What did I tell you? The virus has to go inside the body, then only you will worry, right? If there is no virus going inside, you don't have to worry. So, no prophylaxis measures if there is intact skin. Now, category 2, when there is nibbling of uncovered skin, minor scratches, abrasions without bleeding. When there is skin disruption but no bleeding, which means blood vessel is not interrupted, then what do you do? Vaccinate and give treatment. Clear? Category 3, when there are bites, licks, contamination with saliva, contact with bats as a distinct entity. When this is there, then you will give vaccination, immunoglobulin along with the local treatment. So, immunoglobulin will come when there is beyond abrasion or scratches. When there is bleeding or when there is a disturbance in the skin continuity, then you will have vaccination, IG plus local treatment. Otherwise, just vaccination and local treatment is enough. Now, that lays emphasis on vaccination. Now, all category 2 and 3 exposures are assessed as carrying a risk of developing rabies because there is some disruption in the skin continuity, so they can get rabies. Now, the risk is increased if the biting mammal already is proven to have rabies, the animal looks very sick, animal has had abnormal behavior or animal died, the wound was contaminated by the saliva, bite was unprovoked, animal is not vaccinated and you can't trace any details about the animal. These are all called as the risk factors. In developing countries, the vaccination status of the suspected animal should not be considered. You still would go with prophylaxis for the man, even if you feel it's still a home dog. Post-exposure prophylaxis may be discontinued if the animal is proved by the appropriate lab to be free of rabies. See, the point of giving rabies post-exposure prophylaxis, immunoglobulins and all those injections is not to get rabies for man. If there was no rabies in the animal, man would obviously not get it. So, if you can test the animal, prove that there is no rabies in the animal, then you don't have to worry about what happened to the man. Just treat him only by the local care. Okay. But this is the one which is very difficult for us to do. Therefore, we give post-exposure prophylaxis. Now, there are two types of intramuscular injections. There are two ways in which you give, intramuscular or intradermal. Okay. Now, come to intramuscular. Post-exposure prophylaxis vaccination schedule, you give 1 ml or 0.5 ml into the deltoid muscle or the thigh in case of children less than 2 years of category 2 and 3. There is a 5 dose or a 4 dose intramuscular regime. Intramuscular regimes are SN, Zagreb. SN regime has got a 5 dose regime. Zagreb has got a 3 dose regime. SN has 0, 3, 7, 14, 28. Every other than 3, it is every week. That is SN 0, 3, 7, 14, 28. Okay. This is 1 ml or 0.5 ml of 1 IM dose on 5 days, 5 sites, 5 IMs. Now coming to Zagreb. This is a 4 dose abbreviated one with 2 doses on day 0 and 1 dose on day 7, 1 dose on day 21. So what has it done? From 0, 3, 7, 14, 28, it has become 0, 0, 7 and 21. So this is Zagreb regime. So SN regime, Zagreb regime. Clear? Now an alternative for healthy, fully immunocompetent, exposed people who receive wound care plus high quality immunoglobulin plus WHO rabies vaccine is a post-exposure regime consisting of 4 doses which can be given on 0, 3, 7 and 14. This is a WHO alternative schedule where you will give it to a person who is healthy, fully immunocompetent, exposed people and they have already received wound care plus high quality immunoglobulin. For them there is a WHO alternative schedule of 0, 3, 7, 14. To summarize, SN is 0, 3, 7, 14, 28, 5 doses IM. Zagreb is also IM but 0, 0, 7 and 14, 7 and 21. Then you have another one where the same 4 doses instead of 0, 0, 7, 21, it's made into a WHO alternative regime for immunocompetent individuals 0, 3, 7, 14. Clear on the IM regimes? Now coming to ID. This is intradermal administration for post-prophylaxis administration. The two-side regime will recommend injection of 0.1 ml. There how much you were giving? 0.5 or 1, right? Here you are giving only 0.1 ml at 2 sites on days 0, 3, 7, 28. It is similar to the SN regime but the 14 days IM is not given. You remember the SN 0, 3, 7, 14, 28? 14 one you have omitted and you give only 0, 3, 7, 28 and you give only 0.1 ml intradermal. Okay. This regime may be used for patients with category 2 and 3 exposure in countries where the intradermal route has been endorsed by the national health authorities. So the two-side intradermal regime is 2, 2, 2, 0, 2, 0, 3, 7, 28. So you have less than 2 vials which will be used up because you are using only 1/5 of the dose for intradermal. There you were giving 1 ml or 0.5, now you are only giving 0.1 ml. This is the intradermal schedule. Now for those who are previously vaccinated, this is all post-exposure prophylaxis. Dog bit the fellow, we don't know what to do, so therefore we have given. Right. So for rabies exposed patients who can document a previous pre-exposure vaccination or complete post-exposure vaccination, one dose delivered IM or a cell viro virus delivered intradermally on day 0 and 3 is sufficient. What it means is, if there was a previous pre-exposure vaccination, before the dog did itself, you have already got your pre-exposure vaccination, then you can give one single dose IM or intradermal 0 and 3. Anyone who prior received vaccine does not receive a immunoglobulin again, because he got the vaccine earlier, already immunoglobulins would have been produced. Purpose of us giving in immunoglobulins now is to elicit that response and then make sure that that response comes. So this one side 2-day intradermal or IM regime also applies to people vaccinated against rabies and they have this antibody positive. And as an alternative to this regimen, patient may be offered a single visit 4-site intradermal regime also, because this is one site 2-day regime, it can be single visit 4-site regime as well. So anyone who has been previously vaccinated, you can give a single dose of IM vaccine and no need of immunoglobulin. This is in those who are previously vaccinated. Immunocompromised individuals, more confusion here. Those who are having HIV or immunocompromised, a complete series of 5 doses of the intramuscular vaccine along with a comprehensive wound management, local infiltration with immunoglobulin is required for patients with category 2 and 3. Where feasible, rabies virus neutralizing antibody response also should be determined following the vaccine. Why you want to see the response? Because this fellow is a immunocompromised state. So you want to know whether you would like to repeat the vaccine or give some additional immunoglobulins. So the same routine of 5 doses IM you will give, but you will also do an antibody testing after 4 weeks. Okay. Now post exposure is clear. There are 2 types of it: IM, intradermal. IM has got SN and Zagreb. Zagreb is 00714. Then the other one has got 0371428. You also have a particular scenario where previously if they have got vaccinated, one single IM dose is enough. If the patient is immunocompromised, you must always give immunoglobulin and do a repeat testing. Clear on that? Now coming to pre-exposure prophylaxis. This is all post, after dog has bitten. Now pre-expose, suppose you are going to get a dog or you are going out of country, then what are the guidelines? Now pre-exposure prophylaxis may be performed with any of the modern cell virus vaccines. Traditionally it is recommended for anyone who is at continuous exposure with dogs like animal handler, veterinarian, etc. This has IM dose of 1 ml or 0.5 depending on the vaccine type, or intradermal of 0.1 only on 4 days, 0, 7, 21 or 28. Okay. So 0, 7 and either 21 or 28. So this 3 doses on 0, 7 and 21 or 28 are the ones which are recommended. To lead to significant savings, intradermal pre-exposure should involve enough individuals to utilize all unopened vials within 6 to 8 hours. This is what happens in the government hospitals. So pre-exposure is recommended for those who handle the dogs. It is recommended 0.1 ml intradermal or 0.5 or 1 ml intramuscular on days 0, 7 and 21 or 28, but 3 doses are to be given. Clear? And what Yash asked, whether vaccination is indicated for jackal or bear bite or in the case of cats. Answer is yes. We do recommend even for jackal and bear bites. In case of cats it is usually not recommended, but any animal bite which is unprovoked and you are unable to test the animal for rabies, you would rather give a post exposure prophylaxis. Why? Because the disease is almost fatal. So if it is a bear or a jackal or any other animal, and you have specifically seen how bats are directly constituted under category 3. So, all the animals anywhere which you feel you will not be able to test, then you must give the vaccine. Now quickly let us take a few questions and then go forward. Now, human diploid cell culture vaccine for post exposure vaccination. What is this? So, 0, 3, 7, 14, this should be 28, and then a booster on 90 days. Active immunization following exposure is most commonly given for what? Active immunization is when you are giving immunoglobulin. So, that you have given only for polio. All of the following rabies vaccines are commercially available, except what is not available is the glycoprotein vaccine. It is not yet commercially available. You have the killed sheep, diploid cell and virocontinuous cell. All three types are available. What is true regarding rabies? Incubation period depends on the site. This is the only false one, because diagnosis you will do by the intranuclear inclusion bodies. What are these called? Yeah, Negri bodies. It is DNA and it's caused only by dogs, but it can be caused by other mammals which infect the particular virus. Class 2 exposure animal bites includes scratches without oozing, licks, scratch with oozing, bites from wild animals. So, licks are not included licks on a fresh wound is the one which is included under class 2 exposure. Any scratches with without oozing, with oozing with blood on the palm, this will go into class 3. Bites from wild animals like bats are again categorized as category 3. Now, for treatment of case of class 3 dog bite, all of the following are correct. We will take a pause here. Let us see the answers. Class 3 dog bite, what are the correct answers in this? What is the correct recommendation for this? So, if there is a wide wound, do you want to stitch it or not stitch? Why you don't want to stitch? To enter. So, the recommendation is to not stitch, but to give a antibiotic coverage. By giving an antibiotic coverage, what you will do is, even if there is any other organism which is entering, because of local and also IV antibiotic coverage, any other bacteria which tries to enter, you are trying to handle it. Okay. So, immediately trying to stitch the wound very actively is not recommended. If at all you have to stitch, when will you stitch? Compulsorily after 4 days. Ideally after 7 to 10 days. You must wait for 4 days before you want to do any stitch. Sometimes the gap will be huge, isn't it? In such a huge gap, when you leave it for so long, you will have other infections, Clostridium and others settling in. So, for 4 days you wait, you give antibiotic coverage, you give the immunoglobulins. After waiting for 4 days, over one week, then only you will consider, because by then you would have already given the 0, 3 and 7 days immunization, isn't it? So, any risk which is there, you would have covered it, but you will cover it first, and later on after 4 weeks, if there is still gap, only then you will consider any treatment. Yeah. No, virocell vaccines. Now you have a combined vaccines also. Diploid cell and virocell. IM are all virocell vaccines. Now for the treatment of class 2, so we have already seen this stitch wound. What is the most effective natural barrier to rabies? Water. Site of injection of cell culture vaccine, where is it? Deltoid, we have just seen, but in a smaller child, where will you give? Anterolateral thigh. All of the following are anthropozoonosis except, which is not an anthropozoonosis? Yeah, schistosomiasis is not an anthropozoonosis. Most effective natural barrier is water. Rabies free country is China is rabies free. Anti-serum is available for passive immunization against, we know answer is rabies. You don't have any IGs against any of these. You have an anti-rabies immunoglobulin only against rabies. Pre-exposure prophylaxis dose schedule for rabies vaccine is given in all days except. This is pre-exposure. You remember? Yeah. 7, 28. 3 is missed. You give 2 doses. Now, if there is bleeding from the wound after a dog bite, what are all the treatment? Yeah. So, wound cleansing, anti-rabies vaccine and rabies immunoglobulin. Mortality of rabies, we all know it is 100%. Post-exposure, we know it is not given in typhoid. Dose of rabies immunoglobulin is how much? Yeah, 20 IU per kg. Rabies vaccine who developed? Louis Pasteur.